It's a real privilege for me to be here, and I'd like to thank Aston in particular for inviting me. This is what you could call an ambitious title, so this is basically, I'm going to talk about everything, healthcare outcomes research, past, present and future. So obviously in 45 or so minutes I'm going to have to restrict things a bit, so I thought I'd kind of give you a gentle trot through the stuff that kind of I'm interested in. Now I apologise that this is all related to nephrology, kidney medicine, but I hope that some of this is stuff that would translate into many other disciplines. And this is mostly in the realm now of the data hound, so I'm a bit of a data hound, and we live in a sea of data these days, so it's kind of fairly relevant these days, I hope. So I'm going to start with something very old though. So in chronic diseases, or especially in those that aren't that common, but also in commoner diseases, you could say, things like national registries aren't that sexy. They've been going for years and years and years, and the concepts sound fairly simple. So I'm going to talk a bit about this, trying to make the case that this type of research is really very relevant, even though it's not new, and it's not hugely dependent on technology. Then I'll talk a bit about survey data, which is, I'm really talking about if you go into the community and you start doing something like a close to a random sample of the health status of the community, what you can get from that. And I'll use the American example because I'm very familiar with it, and because I always am trying to get people to start using this data set, because it's absolutely freely available and it's as broad and as long as you could ever imagine. So it's a fantastic place to start research projects, especially for students or for people who you can't expect to do a full Framingham study in 6 months type of thing. It's just an amazing resource. Then I'll talk a bit about different statistical packages and the revolutions that are going on there. And then I'll go on to something that is a bit newer, but fairly straightforward in terms of the idea. So this is trying to automate analysis so that you're not having to bug a statistician, a busy statistician who comes back in 4 weeks' time with the result of the analysis that you've forgotten you even asked for. So trying to automate this stuff and automating reporting. So it's fairly general. Now, disease registry. So say in my game it's end-stage renal disease. So this would be people who end up needing dialysis and transplant. To do this on a national level, you don't actually need a whole lot, but you need to pick up all the cases. So the whole linchpin of a registry is that you get all the cases. And if you've got leaks, you don't really have a registry. So very simple idea, but you have to get the cases. It sounds trite and it sounds almost like a truism, but you really have to have that part. So some registries I think do have great national coverages and some don't. And then to start using the data, then you have to have a fairly good national census system. Most countries have, but not all countries. So then once you go beyond that, you don't really need blood samples, you don't need DNA, but you do need to collect some information. Now this doesn't have to be extensive. Say in the US one, I think in retrospect they probably made the mistake of asking for too much information. So they had so many items to check off that people tended not to check them, especially for things like comorbid illnesses. So a good national registry is a must really if you're serious about your disease. Now the one that I'm involved with is USRDS, or I do a lot of research with it still. This is a publicly available data set. Until recently there was a price associated which was in the thousands. It might be 2,000 to 3,000. It was enough that it might put off an individual researcher. But now I hear there's a push that Medicare, who runs the show, are going to make it free. So keep your eyes open for that. Now you do have to submit an application, and the application is basically to make sure that you're not going to be looking at very small cell sizes. So for some of these rare diseases in there, if you had a table with 3 patients and it was something as rare as hen's teeth, like say Fabry's disease or something, you might be able to identify the patient, so they won't let you do that, and you have to get an IRB to proceed. Now the dialysis and transplant setup in the States is, it actually worked, bureaucracy worked in the favor of number crunchers for once. So in the US historically, Medicare would pick up insurance for people over 65, but they made an exception for kidney disease way back. So at any age, Medicare, which is the what you would think would be older people's insurance, picks up the bill, and everyone who ends up on chronic dialysis or transplant has to enroll in Medicare, whether they're going to use it or not. So this coverage issue is fairly well dealt with by virtue of the bureaucracy. So that's a huge advantage of the US registry compared to others, that there is an incentive to get the patients into the system because they need to get paid. So that's probably unique to the US registry. Now, it's a massive affair, and the data come from all over the place, and there's quite a lot of data cleaning. That's 70% of the effort would be probably collating the data, cleaning the data. So what researchers, if you apply for the data set, you'll get data that's usable probably 2 years. So if you're looking at things like mortality, to be safe, you have to wait for 2 years to pass by. So they're current within about 2 years, sorry. So this is a typical thing you'd see in the registry from the US. And look, here are just numbers of counts, and this is in thousands. So the one that you'd probably be interested in if you're an epidemiologist, you'd be, the population changes all the time, but you'd be interested in incidence. And one that doesn't get noticed, I'm not sure why, but if you look at down here, this is the incidence overall in the population. It's actually been flattening, if not dropping, over the last few years. So when I started back in the 90s, there was an absolute epidemic. The rates were just flying up, and every publication you look at will say that the rates are flying upwards, and in fact for several years they haven't been. They've been tailing off and dropping in many countries. And then the other chestnut you always hear is that it's growing most rapidly in the elderly, and I can't see it, and I've been working with this data for a long time. So in fact, in many groups, the rates of ESRD, end-stage renal disease, are falling in the US or remaining flat. So if you're an optimist, you say this is a good situation. If you're a pessimist, you say why aren't they falling more quickly? But it's certainly a marked contrast to what we used to see even 15 years ago. And I don't know what happened, something around 2005, for a lot of diseases, as I'll show you, things seem to change dramatically. Now, if you then look at prevalence, so prevalence is just the number of people who are hanging around. You get a story. So the story is that the prevalence is actually increasing even more than linearly. Now you'd say, well, that's a good thing because they're living longer, but if you're paying for this treatment, which is very expensive in the US, $70,000 or $80,000 a year for a dialysis patient, hemodialysis in the US, then you have a problem. So even though it's a relatively small segment of society, it's very important from a financial point of view in the US. So prevalence is just skyrocketing. And now this is another typical thing you can do in registries, is if you know the person's address, you can start to make nice pictures. So here, look, we're just showing you the incidence rates of end-stage renal disease in 2011. And these are within relatively small geographical areas. And what's very instantly striking in this map is just the variation within the states is enormous. So you go from places in the lighter colors, which the rate is less than 300, which will be way more than most countries. In fact, you go to areas then in the dark that are almost 50, 60, 70% higher. And then the stuff that's interesting for researchers then is the way it clusters in certain places. So you can see here, look, this is California, and this is Texas, and then there are pockets. This, I think, is Louisiana here. And then there's this thing, it seems to congregate around, this is the Mississippi here, look, Mississippi River. This is where I live here, so we're doing a fantastic job. And then this is the Ohio River. So this is research this geospatial analysis type of research, which isn't unique to nephrology, is something that is very, very, I think, relevant, but it's in its infancy, I would say. Now, moving on then, the traditional way the big registries report kidney diseases, they break it into big categories. and they lump things together. So you get things like diabetes and hypertension. GN is glomerulonephritis, which is inflammation of the kidneys. Now, if you're a clinician, glomerulonephritis is lots of things. So there's a thing that kids get called minimal change disease. That's a form of glomerulonephritis. And then there's a thing called rapidly progressive glomerulonephritis, which is a really bad thing. They're all categorized together. So I think the US did a bad job in trying to go after the individual causes. So there are some causes that would be very relevant to, because they're an indicator of other diseases, how they're doing. So for example, if it was myeloma, what's going on there? End-stage renal disease is a classic complication of myeloma. There are things like scleroderma, all of these things. Lupus is another classic one where end-stage renal disease is an indicator of bad treatment. So the last couple of years, along with a senior registrar from Galway called Donald Sexton and a guy from Scott Rooley in the US, we've been trying to go after the rarer diseases. So we're going after individual causes of diseases. Now, just before I move on to that then, registries are very imperfect. So this is a study we just reported in Kidney International a couple of months ago. And here it's a very simple idea. We're looking at mortality from the very first week of enrollment in the USRDS. And what you can see, if you've ever seen these patients, they're very sick, and they're certainly really sick before they get onto dialysis. So you would think that mortality rates would be very high. But what you actually find, say if you go out to, this is what happens after a year. So something like 15-16% per annum mortality once you get out to here. And then, at between 6 and 10 weeks, this incredibly high mortality. And then in the first week, which you would think would be the riskiest, you're getting very low mortality. So what I'm saying indirectly, this is kind of detective work showing that people aren't registering patients. So the sickest patients aren't actually making it into the system. And there may be financial reasons for that, because in the US on the hemodialysis side, you have to wait for 3 months for the money to kick in. So if the docs have figured out that there's likely this patient isn't going to survive, they may wait to fill out the form. So this tells you then about the difficulties of comparing registries international. That has always been a problem, and unfortunately I'm saying that it's still a problem. Okay, now, so going on to kind of classic registry stuff. This is what's been happening to glomerular filtration rate when patients start dialysis. So glomerular filtration rate is a marker of kidney function. It's the main one we use. And, usually in the old days, 10 would be a number when I was training, when you'd start somebody off, unless they'd got a complication. And then guidelines came around that said maybe you should be thinking about doing things at 20 and instituting dialysis at 15. And anyway, in the US, there's been a very profound shift in the glomerular filtration rate at which patients are starting dialysis. So on the bottom here, look, I've got years. This is 97, this is 2011. And you can see, look, there's been a very easily noticeable growth in the percentage that start with a GFR or over 15. Likewise here. And then you can see, look, that the less than 5 has declined from here to here. And then the 5 to 10 has declined. So, as I said when I was training, would have been like this. So this has been quite a change. So now if you look at that, so I showed you an incidence rate that's flat in the last 6-7 years, and yet we're starting patients at much higher GFR than they were even 15-20 years ago. Maybe the true incidence decline is actually much more. So this is a very simple question. We're going to look at standardized incidence rates. So what ratios? That means if we applied the rates in one particular year and took into account the way the population has shifted in terms of age and sex and race, what would we expect to find? And then we compare expected to what we actually found. This would tell you if things are going up or going down. And to cut a long story short, if the ratio is 1, it means that nothing has changed other than the population has changed, but the incidence within those segments hasn't. And if it's less than 1, we're happy. And if it's more than 1, it means things have gone up. So we're going to ask the question, well, we'll first of all do this standardized incidence ratio regardless of GFR. We don't know that the GFR has changed over time. Now we'll just do the exact same analysis with these different cutoffs. And remember, I said that when I was a garçon, it would have been 10, would have been the number. Well, yes, in Ireland for sure. So, well, what's been going on? So here I'm comparing 2009, 2010 versus 10 years before. So it's 2001, 2002. And maybe the one to look at here is all. So look, that's the number 1. So the 0.97 means that there's been a modest 3% decline in the expected incidence based on rates at the start of the observation period. And then, you know, I go through various subgroups here. This is a kind of disturbing one. In the younger people, it's actually gone up. And then there are some subgroups looked at, it's gone down maybe more substantially here. Here, you know, in Hispanic Americans, African Americans, it's gone down, which is good. And then out in the Western states, it's actually gone up. So overall, you'd say that's modest. Now, but if we start applying the cutoffs, well, what if we try to compare more like to like? So if we take GFR less than 15 as your criterion to get on, then you start to see more optimistic type of trends. So look, you'd say it's an 11% change in 10 years. That's on a population basis fairly profound. And then this issue when the young people actually disappears. And then, you know, you see some subgroups where it's 15% drop type of numbers. So guess what then, when you do it with a threshold of 10, there's actually very profound changes. So on a population basis too, if this is truly happening, if it's truly the same type of diseases, and that there's a very profound shift in the incidence of end-stage renal disease in the States. So, you know, it's a great story for me. Now, this looks like a nice trend. So there are 2 trends going on in the US. The incidence seems to be flattening or declining. And then if you look at mortality, historically, US had the worst mortality, so way higher than, say, Japan and certainly Europe, a bit higher than Canada. Why would that be? Is it something to do with the better care of the disease that's caused CKD? Maybe it's just better all-round nephrology care. So a good disease to start looking at these. So if you start picking the individual diseases, polycystic kidney disease is an autosomal dominant genetic condition, and it's detectable very early on. So if one of your parents or your siblings have the disease, chances are you're going to be asked to get checked. So there's the very good chance that you can pick this up very early on in the condition. And, you know, you have a very good chance of being referred to specialist care, and you have a much better chance then that you will get onto protective treatment. So we said, well, this is an ideal, and the other thing about polycystic kidney disease, there's no actual specific therapy that's in mainstream use at all. There's nothing to make it go away. So they get general nephrology care. So we said, well, that's just a fantastic way to look at how care has evolved over time, perhaps. So we developed our big macro, and we were just living in SAS day and night for a few weeks. And so this was the first one we looked at. Now, just to make sure our numbers weren't, you know, back to front or something in our coding, I just show you what the rates look like in the US. And the one that you'd pick out, like the highest rate of polycystic kidney end-stage renal disease is here. So it's in the age group of 45 to 64. That would tell you exactly what a clinician would tell you. So it seems like we're getting the right group, we think. Now, what happened to the standardized incidence ratio for this one? So if there'd been a dramatic improvement in how we treat the condition and somehow affecting the natural history, this standardized incidence ratio should be coming below 1. So, but sadly for polycystic kidney disease, it's actually stayed flat. So that tells you maybe polycystic kidney disease is not that amenable to treatment. So that's a fairly depressing one. Now, there are 82 individual causes, so you know, we said we should be doing 82 individual analysis. Now, we didn't write 82 sets of code, we wrote one set of code, and we made a nice system to do that. So here are just selected ones that I like, but So what's happened to some of these diseases? Now, we've published several of these, but this one is very relevant here. Like, this is AIDS nephropathy. So in about 10 years, the standardized incidence ratio of AIDS nephropathy went down by 28%. So that's only a decade. A big change there. This other one, we're just about to publish this one. This is myeloma. So as you know, the treatments for myeloma changed dramatically, in the last 15, 20 years, and we're starting to see that now with regard to end-stage renal disease, which is one of its most severe complications. There are other ones then down here, look, the renal artery occlusion, cholesterol emboli, renal artery stenosis, they virtually, I wouldn't say disappeared, but they plummeted. Now, I doubt that that's related to anything biological. I'd say that's because people are doing less angiograms. But another very interesting one then was scleroderma. Not a common condition, but it's one that's got a profound renal abnormalities when they get it. And then lupus, which is in the States is a kind of a fairly common cause of end-stage renal disease in younger females. That's also declining. One of the famous chestnuts of nephrology is this one, membranous nephropathy. It's a form of kidney inflammation that people have been arguing about since the dawn of time, and you should be on this treatment, which is hugely toxic, and that treatment, no treatment. When we looked at membranous, actually nothing really changed for that one. So there had been thousands of articles written, loads of suggested treatments, but no change in the incidence of the disease. And then I showed you polycystic kidney disease. And then the last one is one of the most interesting ones, acute tubular necrosis. When I started, this is the one that you get, suddenly something happens, say, following a surgery or some bad infection, your kidney shut down and you're temporarily dialyzed, and if you survive the process, you go home and your kidneys get fully better. Well, apparently not. So in the US, this has been labeled now as much more commonly as a cause of end-stage renal disease. Now, is that biological? Possibly. It could also be related to how people get reimbursed. So if you're billing for somebody as an acute kidney injury in the States, you'll be very quickly rich. But if you're billing them as a chronic outpatient dialysis type of issue, you don't. So maybe it's something to do with that threshold in the 3 months, I think, is what's going on there, but I can't prove it. Now, moving on, this is more the enhanced type stuff. So around 1999, this classification of kidney disease came out. So if you've ever read a medical textbook, you probably have seen this. So the evidence for these guidelines is about the same as what came before the Big Bang, which is nothing. There was just this fairly powerful lobby came together and they said, let's classify kidney disease. And they said, well, here it is, you've all probably seen the number of 60 as bad. This is based mostly on glomerular filtration. And mostly in clinical practice, this is based on serum creatinine, which is a breakdown of muscle that's difficult to measure. And then we know that kidney nephrologists would tell you regular, properly measured GFR changes all the time. And yet we're going to have to believe this. So, part of our job, as say if you're doing research, is to try and stress the system. So I started to try and stress their classification system to see that things stack up. So one of the first thing I did was with one of the very old iterations of NHANES, which is NHANES 3, very famous one from 1988 to 1994, just millions of pieces of data in it. And this glomerular filtration calculation was using a formula called the MDRD formula, but race was one of the parameters in the formula. So I argued, well, that if this is truly measuring what it's supposed to measure, you'd start to get the complications at the same level of GFR. So things like having anemia, well, not so much in African Americans, but things like phosphate control, calcium, uric acid, all of these things that become abnormal as kidney function drops. If this formula was truly measuring what it was supposed to do and the race parameter was correct in it, you would start to see the complications at the same level of kidney function. And to cut a long story short, it was nothing like it. So this magic number of 60 in a white American, if you were going to do it in an African American, you were going to have to get up to maybe 75 or 80. So this formula to me was not performing as stated. So this is the first one. Very aggressive type of research, but I thought it was worth doing it. Now, another thing, if this fantastic threshold was going to be useful, part of the argument back around the middle of the last decade was that it's going to be useful for picking out people who should be targeted for other investigations. So, would you, if somebody's got a low kidney function level, so GFR less than 60, would you go measuring hemoglobin, parathyroid hormone, lots of stuff? And so we said, well, why don't we check how we pick up these complications at different thresholds of kidney function? And this is an ROC curve, so I'm showing specificity for picking up all of these abnormalities and sensitivity here. And in sensitivity specificity research, a toss-up you get 0.5. So 0.5 is as bad as you can do. It's not like an R-squared test where you think, oh, that's not bad. This isn't the same. This is a C-statistic type of thing. So it actually was performing very poorly in a community setting. So it wasn't really clinically useful in the community to use this as a kind of a threshold to go to further testing. And then finally, there was really a big kind of a hoo-ha about this just rising prevalence of kidney disease in the general population. So a study came out around 2007 based on serum creatinine. So they measured creatinine twice with different instruments in something that's famously difficult to measure, and they said that the prevalence of kidney disease in the US had gone up by 50% in 10 years. And if you think about that in the community, not end stage, that's an enormous change. So I said that couldn't be true. So NHANES also had this analyte called cystatin C, which was supposedly a more accurate measure of glomerular filtration rate. And it had the advantage that they did samples in lots of people and they used one assay. So we went and looked at that. So when we compared these two timeframes as in the previous study, the cystatin C levels were identical. So with the better analyte kidney function, it actually not changed at all. So these are just examples of the stuff that you can do with NHANES. It's a fantastic resource, and it's not a nephrological resource, it crosses all domains. And not alone that, then it's in the last 7 or 8 years they've become more friendly about leaving out their mortality dates. So these data are linked to the National Death Index in the US. So it's freely available. You need a little bit of help to start analysing it, but very useful. And then having the mortality data means it's like the Rolls-Royce of data sets. So I would, it's if you're trying to build up an observations department and you want easily to perform but very relevant projects, this is a great place to start. So now this is then one of the around the time I started to get into heavy duty macro processing by accident really, but it's relevant. So this again is NHANES 3, and this was trying to address the question, if you go to a bunch of nephrologists, I was actually trying to get rid of the question. I said, I don't believe this threshold of 60 garbage, and so they're saying you should be screening for kidney disease, and then the cholesterol people are saying you should be screening for serum cholesterol, and the blood pressure people are saying you should screen with blood pressures. You can't screen for all of them. So I was trying to address the question, well, if we picked our best threshold and you picked your best threshold, who would win? So that's what we did. So here was the first thing we looked at. So this is urinary protein excretion. So this is albumin to creatinine ratio. And the magic number that the gurus were telling us was that 30 is a bad number. So I said, okay, well, let's look at the threshold values for predicting mortality and just vary the threshold all along. So I'm not going to make any prior assumptions. I'm going to find out what happens at various thresholds. So if you go over here, look, this is this number of 30. 30 is abnormal in this classification system. And now I'm looking at mortality. So sensitivity for mortality means that you're picking up those who actually died in the follow-up. So basically what this is saying, like this number is about 25, 26%. You're actually missing 75, 74% of the people who actually died. So you would say that's not great because you're actually missing most of the people who died. On the specificity side, you're doing reasonably well actually because you're over 90%. So what that is saying, if you tested and you were negative, you'd be happy enough to exclude them, say you don't need to come and see me anymore, bye-bye. So it's testing its usefulness in this scenario as a negative test, which isn't what the screening people want to hear at all. But so I started to, as I said, I varied all the thresholds, and the number that comes with the highest combined sensitivity is specificity. So I'm saying I value predicting negatively as well as positively. I want to get the most bang for my buck. It's actually very much in the normal range, and screening tests that go into the normal range they're not efficient because you're ending up screening everybody. So in this framework, it wouldn't make sense to screen. This isn't a randomized trial, but it still wouldn't make sense just based on the numbers. And then we did the same thing with the GFR levels, and it was the same story. The suggested threshold was not picking up the people who died. So down here, look, it's still 75% of the people who actually died in the study wouldn't have been put into your bucket. But then it predicted very well on the negative side. So if you didn't have the GFR less than 60, it was helpful. But again, if you start to go for the optimal threshold that combines sensitivity and specificity, you're up around here. So you're getting into the normal range again. So this isn't stuff that people want to hear, but it's unfortunately it's just the way it is. And remember, this is more or less a random sample of the US. Now, so we did this process. We went through all of these variables. So we looked at everything that you know that would have been suggested in the public health literature, and we just let the computer pick the best threshold. So surprise, surprise, age was the winner. No surprise actually. So the threshold was 57. Now what's surprising, it's not intuitive. You would say, wouldn't that be 95 or 96, because shouldn't it be very old? The reason it's at 57 is you get credit for predicting on the negative. So if you predict that someone survived correctly, you should get credit. And if you predict that somebody was going to die, you get credit. So this would be the dominant one. The next one then was actually a GFR. So a kidney function test was better than any of the other lab tests. But unfortunately, the threshold now is 94. That's well into the normal range. And then for blood pressure, this is the third best. So these are more or less the same. GFR was slightly better than blood pressure. Systolic blood pressure was the next thing. And then you can work your way down. Here's another kidney one. Here's waist-hip ratio. Here's glucose over a certain level, etc. And then these are clinical diagnoses. So the kidney functional parameters actually stacked up relatively as well as the other things, but neither was really that good. So in this general population random sample. And then you can do this recursively. So I said the first cutoff was 57. So you select the people under 57 and you start this process again. Now this is heavy work. It's a lot of computation. And you work your way down, and eventually you just don't have statistical power anymore. So as you work down through 1, 2, 3, 4, I think 4 nodes, you stop. But this is useful because it tells you, it makes no assumption about what's important in whom. So here, look, it's in the young people, it looked like having a blood pressure over 120 would have been the dominant predictor. This is what a lot of people would tell you beforehand. And then in the older people, it was urinary protein. And what was kind of instructive to me was that classic things that we're all worried about do appear. So body mass index and cholesterol, they turn up, but nowhere like as high as you think. So in this threshold system, it's a different way of looking than we normally do. Things look quite differently. So this is a decision tree. Now, so this was a lot of work, as I said. The Haynes decision tree was just, it took me a while, and then things started to click. But around this time, I'd become interested in this other software called R. Now, I don't know what to use at UL. I suspect it's SPSS is the dominant player here, is it?
And R as well.
Okay, great. Oh, good. Speaking to the converted. So, I've worked in all of them. I started with a thing called BMDP, which was Fortran, and we used to use SPSS to line up the data. And the University of Newfoundland decided to get rid of BMDP, so we were on SPSS, and then I went to the States, started using SAS. I've always believed that you have to work on at least 2 platforms to get the most out of your information. So I'm glad to hear you're using OR. So OR is the biggest revolution in this analytical world since forever, because it's freeware and it's research driven. So there's no real commercial agenda driving the back end of it. And it gets very responsive to needs in the analytical society. It's, as you know, if you use it, it's a little bit quirky. There's a learning curve, but there are lots of resources out there, lots of cheap books too. So if you have a Kindle or something, you can buy a book for $30, $40 or euros, you'll get it. So OR then, to me, is it's way better than any other statistical package in that it's the interface with the graphics. They've really got seriously into that. So I can't have shares in OR because it's absolutely freeware, but it's where it's all going, and I suspect it'll probably eat out its competitors in the next 10 years or so. But so I've been really getting heavily into OR in the last maybe 3-4 years. Now the last thing. This is called. Now I'm going to ask you to repeat this when we get finished, but this is a macro. So I've been writing a bit of code, and I've always been struck that I tend to do the same things all the time. There are variations. I get a data set, and I want to describe the people at baseline. So I have a starting data, I have an ID, and then I want to describe their age and their sex distribution and the percentages with all these comorbidities. Always starts off like that. And usually then there's something variable of interest that I might be interested in heart disease, say. So I end up doing something like that where I compare all these baseline variables according to the presence or absence of heart disease. And then I probably want to look at this candidate variable for outcomes. So I might be interested in survival, always in that. I might be interested in other clinical outcomes. And the analysis start to all look the same, but the data looks different and the names are different. So I've been saying to myself, why wouldn't I just develop one system for all? So this is my any dataset macro. So as you deal with more and more information, which we're at that stage now, there's information everywhere. Datasets come across your eyes all the time. And then there are people who have just fantastic data but are afraid to use it because they're not trained in using analytical software and they don't have the time to learn it. What if they had an embedded macro on their computer that would just do all this for them? So how this would work for me, and this does work. Look, I come in and I say, here's the data set. I just call it X here. And you tell me the name of the variable that says ID number. You tell me the class variables are things that they're categorical variables, like the color red, the color of your eyes, sex will be. And then you just name them for me. You tell me the number of categorical variables there are. You tell me the number of kind of numerical type variables. And then you tell me the types of analysis you want. Do you want a chi-square? Do you want a t-test? Do you want a logistic regression? Do you want a Poisson regression, Cox regression? Do you want a case control study? Do you want a Kaplan-Meier curve coming out, etc.? Do you want to do a competing risk analysis? And out the stuff pops. And I think this is where university departments are going to have to go to compete, survive, and to let people ask questions and address them quickly. So with this type of approach, which I also use for NHANES, basically someone walks in your door, they've got the question, you just give them the technique, and it takes all the mythology out of the analysis. The only thing is that you have to be sure that you set it up correctly at the start. But I'm a physician who codes, but I wouldn't have a license for coding. But this isn't rocket science by any means. But it takes a little bit of time. But as an institutional investment, I think this is the way to go. So the last thing I could do then is I could say, do you want to export this to a folder? Name the folder. So you send an Excel sheet or whatever you like would come out as a folder at the end of this. So this might, on a good computer, this might take 3 minutes, depending on the data set. So it wouldn't be 3 weeks like I was saying, it could be seconds. So it's speed and automation. I sound like Big Brother, but that's the way it's going. Now, This is a thing that is also, I'm very interested in, just as a workload thing. This thing of reproducible research. So I'm sure you've all done it. You're working in SPSS and you have a tiny screen and you're minimizing the screen. You get the result, press click, then write the thing into the table. And the amount of transcription errors we do doing that must be enormous. And then the time we waste doing that. Now, if you set up your macro properly, you should be able to get something that looks like a table. It should come out as a fully formatted table. So if that is the case, you can never have a formatting error. You can't just write down, 10.01 when it was 100.1. And if there's a big movement especially in the R world, but also within SASTAT, to do this reproducible reporting type of stuff. Now, I'm no expert on the PDF version of this, but there are things that even some of these you can do quite simply in R. There's a program called R to Word that I use fairly heavily. So when we were doing this 82 rare disease stuff, we had the system where we plugged in the number of the disease, SAS ran it, exported the data into a folder, and then we wrote the paper for us literally, so the paper would come out, everything written. So I'll just show you an example of this. So has anyone here used R to Word? It's a really powerful little package. So I'll show you this is a piece of code we have from it. Look, I have string 31. That's just my naming code. What the string 31 is indexing this table to the right. It's saying go to the code that I make string 31. It says go to row row 4, column 5. So it'll pick that number. And then I say go to began RRT because of the next string. So I've named the disease. That would have been lupus. That would be row 2, column 3 in this one, etc. So when I do that, look, it'll come out as so. Now if I change the disease, it'll come out exactly whatever number is the appropriate number there. So if the output from your big macro stuff is always going to be the same, you actually have self-writing papers. And we literally did. So we had the abstract table results, the whole lot fully formatted. It would come out. It's really very slick. So this is stuff that takes the time out of the work. So the upfront time is what the problem here is. Like, I don't want to do that. Writing maybe 70 or 80 strings into a piece of text takes maybe a day, but the time you save on the back end is unbelievable. So you could see that you could apply this all over the map. It can be every paper I've ever read starts with the number of subjects included was X. Well, you can automate that. The mean age was X. The sex distribution was percent male, percent. They all start like that. And if you know the technique you're using, you can really start to automate that. So that's the way it's going for me at the moment. So I think I'll stop here. Absolutely data everywhere. There's too much data. There can never be too much data, but we're just really swimming in data. It's a great time for a number cruncher. I think we have to take the methodology out of analysing the data. I think the separation between analysts and people who ask the question, I just don't see any sense in that. I think there should be a lot of, I think that's the theme of the whole morning actually, but this cross-pollination is really important. And I made a big play for R. I think it's definitely the way to go. This multi-platform approach, you have to. I think you will always come to some crossroads where you can't depend fully on one platform. The programming, I don't think, is as difficult as people make out. And then the systems, if you can identify someone who will push a system for you, I think you can really advance your program. So thanks very much.